I'm Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI, and you are listening to JAMA AI Conversations. My guest today is Dr. Sarah Hull, a board-certified cardiologist whose clinical practice is focused on echocardiography and cardiac care of cancer patients. Dr. Hull is also the cardiology course director at Yale School of Medicine, where she also serves as Associate Director of the Program for Biomedical Ethics. Thank you so much, Dr. Hull, for being here.
Thank you so much for having me. It's really an honor to be here talking with you today.
Thank you. Can you tell me how you got your start in really talking about how AI is influencing decision-making in cardiac care? Is there an instance where you really felt that this really needs to be discussed and this needs to be further investigated?
So one of my personal and professional missions is really advancing conversations about the practice of biomedical ethics within the field of cardiology, which is a field where I have to say there is a lot that we can do, and that increases every year. We have incredible medical therapy, we have incredible procedural therapy, but we do tend to focus, I think, a little bit more on asking the question, can we do this? And maybe not always as much on the question, should we do this? That's not to say that I think that we need to be in a moral panic about AI. I think, like any other technology, it's a technology that is going to start out as somewhat ethically neutral, but recognizing that in the way it's deployed, it could be deployed in a very ethically robust way or in a very ethically dubious way. And that's the responsibility of those of us practicing medicine and those of us also, of course, making policy to make sure that we enact guardrails such that it's deployed in a way that's really ethical and that's advancing patient care and patient interests and not undermining them.
Thank you. Yes. And, you recently obviously wrote about that in JAMA. And one of the things that I want to ask you in follow-up is, what have you seen that has been one of the biggest moral dilemmas that you think we're facing with AI, especially within this area?
So that's a great question. I think that we need to be very careful when deploying tools that act human versus tools that are decidedly not human acting. I think that ethically it can become a lot more complex when you have really advanced generative AI that can seem very humanoid, but very importantly, does not possess moral agency and does not have a fiduciary responsibility for the well-being of the patient. And therefore, as I've argued in the paper, while it can be very helpful to use AI tools as sort of a second pass mechanism or as a supplement to clinical judgment in order to help with interpretation or sometimes even decisional support when there isn't a clear right or wrong answer and we want to really incorporate a lot of different data sources in helping us to make our decisions with patients, of course. I think there needs to be a hard boundary where we say we can't deploy this for tasks that require moral agency. So I can't foresee a time in which it would be ethical to say, well, because the AI chatbot actually has been shown to be more sensitive in delivering bad news, we're going to have our chatbots deliver bad news to patients instead of clinicians. That, I think, is sort of categorically an area that we should stay away from. Any task that requires moral agency, we should not be delegating to an AI and as the primary deliverer of that task. And then even with other tasks, because the machines don't have fiduciary responsibility for patients, physicians and other clinicians do, we have to view these tools as a supplement rather than a replacement for what we do, at least clinical tasks. Now, administrative tasks that do not require moral agency, that's a different story. And that's an area of potential where they may actually serve a great purpose and hopefully help to relieve us of some administrative burdens. Although I am a bit cautious about that because I think, we heard that about EMRs as well, that, everything would be more streamlined. And in fact, the opposite has been true. So a lot of technologies that have promised to free up time actually have just serve to really chain us to them. Even if you look at email, email is a lot more efficient than regular postal mail. And yet I think most of us feel quite chained to our emails. And so I don't think that really has served a liberating role at all. So I think we need to be very cautious about unintended consequences and overestimating the efficiency benefit of these tools.
I love what you said about not necessarily liberating, but being chained to it. And I love what you said about email because I feel that way about text and Slack and the billion of other messaging tools that you have to now answer.
Yes.
And so the EHR is a very good example. Going back to this idea of AI not having the emotional intelligence, right? Or the human judgment that humans do, throwing in a curveball in there, theoretically, programmatically, you could program AI or what we all fear is a robot kind of taking over.
Mm-hmm.
I give the example. I don't know if you know the story I, Robot, the book and then the movie, where you could program a robot to follow the rules to ensure that the safety of humans come first, right? And so, do you think that there will be a point where we do have AI be making those type of decisions or be doing all the way surgery or, making those kind of final decisions and replacing human care?
So I think there are two separate questions baked into that. One of them is, do I think they will? And one is, do I think they should? And, it's, do I think they will? I'm a bit hard pressed to answer that as someone who is not an engineer and designer. I'm really not sure that I'm the best person to answer that specific question. Do I think that they should? I think that, again, we need to sort of break down different questions. What is our actual goal? So is the goal, are we asking about what's going to get us the best outcome? And how do you define what is the best outcome? So, if it's a purely technical question that clearly every person will agree that this outcome is better, that outcome A is better than outcome B, I can potentially foresee a future in which people might say, yeah, I might want to delegate this task to a robot when clearly, let's say it's a surgical procedure, when clearly the robot has better outcomes with this surgical procedure than a human does. I can understand that we practice evidence-based medicine, and if the evidence shows that outcomes are better with a machine than with a human, I can understand why it might be tempting to want to put the robot in the front seat. But then the question is, what if there is a complication then? Who's responsible for that? Who is taking that ethical responsibility, that fiduciary responsibility? Because the robot's not taking it because the robot doesn't have moral agency. So is it the person who designed the robot? I don't think so. You can argue they should, but I don't think that that is realistically where things are going. And someone kind of needs to own the repercussions, the ethical repercussions of that outcome. And so I think that question needs to be answered before we would ever move to that sort of scenario. And I think ultimately the person who is going to take responsibility for that is still going to be the clinician. And I don't think clinicians are going to feel comfortable taking the responsibility for that if they're not somehow involved, even if it's simply overseeing the robot to make sure that the robot is functioning properly. And you might quibble with my use of the word a supplement rather than a replacement, because maybe it is serving in more of a replacement type capacity then, but you still have some human oversight. I think it's going to be hard to imagine the lack of human oversight just because someone needs to take responsibility for that. And I'm hard pressed to name someone other than the clinician who will. But I think that only answers half of the question. So I think that the fact is, though, as I also argued in the paper, medicine is not just a technical endeavor, it's also a moral endeavor. And so there are a lot of cases where there isn't going to be objectively one favorable outcome over another, where many patients will say, well, I would much rather have outcome A in this scenario. And then other patients will say, well, I would rather have outcome B. And this is why, because my goals and values and priorities are different. And so who's going to do the moral work of interrogating those goals, values, and priorities? Again, are we asking the robots to do that? I'm hard pressed to imagine that being something that's satisfactory. I have not used, but I've heard on other podcasts that there are chatbots out there that imitate sort of romantic relationships, but that one of the major criticisms of them is that they're a bit too frictionless, meaning that they actually are poor substitutes for real relationships because there's no conflict because, again, the robot does not have personhood or agency or needs of its own that need to be fulfilled. So superficially, it may feel good to have a robot saying everything you want it to hear, but that actually isn't going to give you the relationship satisfaction that one is looking for from an actual meaningful connection with another human person with moral agency. And I think that certainly as a patient, I want that from the person taking care of me. And so even if the frictionless robot never puts its foot in its mouth, and goodness knows I've put my foot in my mouth, I will probably do it during this podcast interview at some point if I haven't already. And I'm just blithely unaware of it. But that's the human condition, that we are imperfect. Sometimes we say things clunkily and then we have to repair those relationships. And yet those are real relationships that we create that I just don't think that a robot's going to be able to create them. So again, a task that's purely a technical task, I think will be more amenable to delegation to a larger extent to robots versus tasks that really are moral tasks that I just don't think ethically should be delegated to a robot for the reasons I've articulated.
No, I wholeheartedly agree with you about the relationships. I love the analogies that you give about like a frictionless type of relationship, right? I think it's also why, we're going online and we have more connections, but we're seeing that people are more lonely.
Right.
Right.
Those connections don't fix loneliness because they're not real. That's exactly right.
Right.
Exactly.
And I go back to, the Terminator and Sarah O'Connor
Yes.
and them talking about how like, he'll always be there. He won't ever raise his voice. He won't ever hit, but they also won't give the love and affection and the connection that I think, again, that is part of medicine, that as what you talk about. But let me ask you, though, I think a lot of hospitals and a lot of institutions are already kind of integrating, for instance, generative AI into healthcare and potentially not also being transparent. So patients are talking to a chatbot when they don't know it. So what are your thoughts on that? And how do you kind of prevent this over automation and generate guardrails to ensure that we are giving the relationship that people need and patients need to heal?
Right. So that's a great question. And I think the first step really has to be transparency. And that's not to say that transparency in every possible context is going to be either feasible or even ethically necessary. So again, going back to questions of, for example, using interpretive AI as a second pass to verify one's impression when reading a diagnostic imaging study, for example. That's just another technical tool, like many of the tools. And just like I don't believe, and I think in general, there's a pretty reasonable consensus that we don't need to disclose to patients we're using this brand of imaging software versus that brand of imaging software. I think for something when we're just adding an additional enhancement for interpretive purposes, I think it's really hard to argue that there's an ethical need to disclose that, and also that it's going to create some feasibility issues. But again, I think generative AI that's directly interfacing with patients, I think there are a couple issues at play. Number one, of course, is just the transparency issue. If a patient believes that they're interacting with a human and they're interacting with a machine, then that's deceptive. So that's clearly ethically problematic. And then another issue with generative AI is that there are a lot of data security and privacy concerns that those may be collecting a lot of sensitive data if they're interfacing with electronic medical records. So there needs to be a lot of algorithmic transparency and assurances that this data is not going to be shared outside of a health system because they're using some proprietary algorithm that has a black box with respect to how it's using the data and how it's keeping the data. So I think there are transparency issues and privacy and security issues, and all of that needs to be really discussed explicitly prior to rollout. And I think something like that, it needs to be really quite explicitly explained to patients that if they're using some sort of communication portal that's going to be relying heavily on chatbots, then I think it needs to be disclosed to patients that that's going to happen so that they're not, because otherwise it's kind of hard to argue that we're not bamboozling them, whether intentionally or unintentionally, or I should say whether by omission or commission. That's still problematic if we're doing something in a deceptive way. Whether or not our intent is to be deceptive, if our impact is deception, then I think that that's ethically problematic.
If you could have AI in the room with you as a provider, what would you have AI do? What do you think AI is the most useful for when you're in that scenario?
I will say that I don't even like to use a scribe because I feel that that's, an extra person in the room that maybe doesn't need to be there. I recognize sometimes you need an extra person in the room. So this is less of an issue in cardiology, but for example, in gynecology, often there needs to be a chaperone for sensitive exams. I completely understand that when a patient, I speak English and French, but I don't speak any other languages. So if a patient doesn't speak those languages, I need an interpreter. Obviously, that's another person in the room that's absolutely instrumental to that patient getting the care they need. So I'm certainly not criticizing the decision to use a scribe if other physicians find that that helps them to free up time in order to have more face time with their patients. So I want to be really clear that I'm not at all criticizing that. But for me personally, I can type very fast. And I have a system of pre-charting such that I really don't need to interface with a computer very much most of the time when I'm meeting with the patient. Sometimes for the initial visit I do, but for the most part, I will try to sort of pre-chart everything so I have a sense of what I want to discuss and what our agenda is going to be, recognizing that the patient may have a very different agenda and I may need to pivot a little bit or a lot. But I really try to minimize the intrusion of tech into that interaction with the patient. I think patients really appreciate that. Now, they also understand. Sometimes they'll tell me a lot of detail and I will say, but again, I'll be explicit rather than just turning my back to them. I will say, you know what, that's a lot of information. I want to make sure that I get that down and that I remember that for future visits. So do you mind if I just turn to the computer and type for 1 minute? And usually patients really understand that. And I think that's a very different dynamic from me spending the visit turned around or half turned to them with more of my attention on the screen than on them. That's a long way of saying I don't think I would want AI in the room with me. What I do think it potentially be helpful with is if there were an AI tool. I think one of my areas of focus in cardiology, and particularly in cardio-oncology, is lifestyle intervention. I think that this is actually another big area of ethical importance that is really underappreciated in cardiology and also in medicine in general. So poor diet has surpassed smoking as the number one risk factor for death in the United States. And yet, it's something that, if you look at the kind of food that is served in hospitals and clinics, that's sold in hospitals and clinics, there's a lot of very heavily processed food, a lot of sugar-sweetened beverages, a lot of red meat, all foods that we know really undermine health. And eating an unhealthy diet is so normalized in the United States. The standard American diet is a very health-undermining diet. But I think because of that, because we live in an environment in which the default pathway is eating a very unhealthy diet and living a sedentary lifestyle, and to be as active as we know we should be, and to eat a predominantly whole food plant-based diet in accordance with what the data show us, or, a Mediterranean diet, like a green Mediterranean diet, a DASH diet. All of these are patterns that are foods that minimize animal products, if not totally exclude them, and that minimize processed food, which we know promote health. But we're really not very good on the whole at helping patients to make these changes. We're good at prescribing medications. And I want to be clear, we need to prescribe medications. I'm certainly not trying to espouse this false dichotomy of meds versus lifestyle. For many of our patients, they do need both. But I think it's a lot harder for us to, quote, prescribe lifestyle changes because those aren't things that can fit neatly into a pill and be taken once a day or twice a day and be forgotten about. Those are things that really need to be constitutively on. So, I do wonder if there are AI tools that could provide support to patients once they're outside of the clinic. I'm not aware of any tools like this, but tools that empower patients to make healthier decisions that maybe, again, going back to talking about lowering the friction, I'd like to see less friction in the pursuit of healthier choices, because right now the pursuit of unhealthy lifestyles is so frictionless. And there are so many barriers, financial barriers, educational barriers, just spatial barriers for people who live in food deserts to eating healthier food and just having a healthier lifestyle in general. And if there's a way that AI could be harnessed to help counter some of those social determinants of health, that would be at the top of my wish list, frankly, because I'm not really interested in having AI in the room with me and my patient. But when I can't be there, maybe there's a role that they could play. Although, of course, again, I would want it rigorously tested and to make sure it's not giving bad suggestions that go against what the medical evidence would suggest. And of course, be culturally sensitive, be sensitive to a patient's socioeconomic circumstances and other circumstances, because I think sometimes we can be woefully unaware of those in the medical profession, although we're getting a lot better. We still have a lot of work to do, though.
What are you hoping that AI is going to bring to us, in the next 5 to 10 years?
I hope for a few things, but probably if I were to choose the top priority, it really would be I'm going to choose two, which would be that number one, that it would improve the quality of the care that we provide by giving us an extra level of precision, giving us an extra level of interpretive support or decisional support in difficult cases, and then also improving access. So is there a way that AI can be leveraged to, again, lower some of the barriers that some of our most vulnerable patients face in terms of accessing healthcare? Although I also want to be very cautious there, because once again, going back to this concept of unintended consequences, I think we need to be careful that we're not using AI as a patch for the fact that vulnerable patients have trouble accessing care. So we'll allow them to access a certain level of care, but they don't get as much face time with clinicians as patients who already are more privileged. So we have to be really careful that we're not creating doubly disadvantaged patients by creating a two-tiered system in which AI is being disproportionately leveraged for people who already are underserved by the medical profession. And another thing that I've heard used as an argument for implementing or incorporating AI, but it makes me very cautious, is the question of efficiency. So I think, of course we all want to be efficient, but I think we do need to recognize that efficiency and speed are not the same thing. And that if tools are helping us to do things faster, but are compromising quality or are compromising the experience that the patient is having and is not meeting their moral needs, that just because it's enabling us to do something faster doesn't mean that that's sort of an unmitigated good. Efficiency is a great thing to have, but true efficiency is doing the best job you can in the least amount of time. It's not, how can we just increase our throughput? And, if we can't offer something that's quite as good, but then we can help more people. I think we need to be very cautious there, because that obviously is not what our mission should be, that we shouldn't be. I don't think, if we put ourselves in the shoes of patients, I don't think most patients are going to feel very good about a system that has said, well, already I think patients feel that they're shuffled in and out too quickly at times, that the system is overburdened, which I think it is in many ways. But I don't think the answer to unburdening the system is by trying to squeeze more and more throughput out of the same number of clinicians just by saying, well, use AI and so you can see people faster, but not see them in as comprehensive, as complete, as high quality, and as compassionate a way. I think that's really going to further undermine what our mission is, to give the best quality care to as many patients as possible. And I think also there's a great potential to increase burnout, which we've already seen, of course, with EHRs.
I think my worst nightmare is that healthcare will become like calling a customer service line and getting a robot, or getting a chat bot, and just never having an interaction with like a human being. And yes, they can answer basic questions, but they also don't understand a lot.
Right. And even if I think I told you, well, if we have an AI do the first pass, we can get you into clinic tomorrow. But if you want to wait for a person, it's going to be 2 weeks from now. I think unless it's a really, really simple question, most people will wait 2 weeks for the appointment. And if you really need medical attention that quickly, you probably need to go to the emergency department. But, to that end, I do think having good empirical grounding to sort of back this up, and using models such as community-based participatory research to make sure that we are engaging diverse stakeholders in different communities, including communities of more historically vulnerable populations, to get a sense of, well, what are their priorities? What are their concerns? What would they like to see AI do for them? Not just what would we as the profession like to see AI do for us? I think that's going to be an absolutely critical piece in terms of ensuring the most ethical deployment of AI going forward.
That's great. Well, thank you so much, Dr. Hull. It was really excellent talking to you. I really enjoyed our conversation, truly.
Me too. It was such a pleasure. Thank you so much.
I am Yulin Hswen, Associate Editor at JAMA and JAMA Plus AI, and I've been speaking with Dr. Sarah Hull about using AI to manage decision-making in cardiac care. You can find a link to the article in this episode's description. And for more content like this, please come to JAMA's new JAMA Plus AI channel at jamaa.org. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.